Okay.
Happy birthday. Is how you want to spend your birthday?
She came over and she made lamb. Got me full of garlic. Then she made chutney. And then, do you know what tzatziki sauce is? If you have a gyro, Greek gyro,
Oh, yes, yes,
that
yes, yes.
tzatziki sauce, it's made with yogurt and it's wonderfully good.
Yeah. Yeah.
And then she got some naan and she barbecued the naan and put naan, heated the naan.
That sounds very good.
She loves to experiment. And she cooks a lot of recipes.
Yeah.
She never uses the recipes.
That could not be me. I'm so bad at cooking.
You know, I was bachelor for years.
Yeah.
Probably should eggs.
Yeah.
Recipe for eggs. And for making, you know, pancakes or something, use the back of the box.
Yeah.
Back of the box.
Easy enough to do.
And I mean, they can do this.
Which one was it? Was it
Number
quiz
10?
10? I didn't take that yet.
You take that.
No, I didn't.
Right here. You want to take it now or you want to wait? Okay.
I see a grade versions, but I don't think I missed any.
It's in my email.
Oh.
After 2 classes, I had quiz grades this year.
Oh.
After it was here. So 262, 1 quiz grades disappeared. And then my other farm class and the quiz grades disappeared. Just gone.
Did you hand them, are you saying that you, like, they're not in the grade book, but you handed them back?
I'm saying that they were in, yeah, I handed them back. They were in the grade book and then they disappeared from the grade book. So only had that happen once before.
Can I give you my quiz back?
You can show it to me and I can put the grade in, yeah. So the self-test on the back table, if you could take that self-test and just kind of look it over and try to dredge up.
Okay, that's the one that's missing.
Yeah.
All right. So we'll fix that. And folks on Zoom can't see what I'm doing because I have to show it to them. Okay, so quiz number 9. That's okay. All right. Oops. Wrong one. One space. There. There. All right. Good. Okay. There we go. All right. Back to this. Back to this. Okay. All right. Welcome, the few, the dedicated. We have several people on Zoom, as you can see. Well, no, maybe you can't see what happened to. Yeah, yeah. Oh, I turned that off. Come on. There. All right. All right, so if you take the self-test out, so the first question is which of the following is a tier 1 form of contraception? Tier 1 forms of contraception consist of what? IUDs? What else? Implants, subdermal implants. Are they the least effective or the most effective? Most effective. So they're the ones that have the lowest rate of treatment failure. If you have failure, it's in the 1% range. So if we look at these, the Depo-Provera injections, that's a depot shot of a long-lasting progesterone. Is that a tier 1? That's like a long-lasting mini pill. Are the mini pills tier 1? No, it's tier 2. So Depo-Provera is not. Xulane. Xulane is a dermal synthetic progestin and synthetic estrogen. Is that tier 1? No. Dermal patches are like the oral contraceptives. That's tier 2. Paragard, copper IUD. That's tier 1. The other two, the Seasonic and the NuvaRing, the rings are also, they release synthetic progestins and estrogens. Those are tier 2 as well. So Seasonic, that's a combination, combination oral contraceptive, that's also tier 2 as well. So Paragard's the only tier 1. Which of the following are important instructions to give to people who want combination estrogen, progestin, oral contraceptives? Select all that apply. So think about the side effects, things to watch for, the ways you should take a combination oral contraceptive. These pills do not protect against STIs. Is that true? That's true. Do a lot of people think they do? Yeah, they do. So should you tell the patient that? Yes. Yes. Tell the patient they do not protect against STIs. Absolutely. Which sort of contraceptives do protect against STIs?
Condoms.
I just heard it from McKenna online. Condoms. Yes, condoms protect against STIs. Two, take these pills at the same time each day. Should you tell your patient that? Absolutely. It says that in the drug insert. Same time each day. In fact, now there is a phone app you can get apparently on your phone that will track your menstrual cycle and will actually remind you when to take your birth control pills every day with a little alarm or a little buzz or a little whatever. So these apps are actually available to do the reminders as well. You should ask them to put one of these on their phone, and you should probably have them download it right there in the office and set it up. These pills should be taken with a high-fat meal. Do they need to be taken with a high-fat meal? No. No reason to take them with a high-fat meal. They can cause nausea. Taking them with food may abate that, but there's no indication a high-fat meal decreases the nausea at all. You should expect very heavy periods with this medication. Okay, Rebecca's shaking her head, Maddie's shaking her head. Why is that wrong? Tends to shorten periods, tends to make the periods less heavy. So that's just not true. You don't want to tell them something is not true, right? Trust is earned, remember. If you take these pills during the first 5 days of your period, then no backup contraception is required. Otherwise, you should have backup contraception for about 1 to 2 weeks. Did you tell them that? Yes. Yes. Takes about a week for it to start working. They should have backup contraception. They're not going to start working right away unless you take them during the first days of your menstrual cycle. You start them right away, then you need backup. If you wait until your menstrual period to take them, then they'll start working right away. Question 3. If a patient decides she wants to have Nexplanon subdermal implants, then select all that are possible. She must have backup contraception at the ready. True or false? Once it starts working, does she need backup contraception? No, no. This is a tier 1 contraceptive. You don't need backup. She does not need to worry about taking any pills for at least 3 to 4 years. Is that true? That's true. It is an implant. The implant doesn't require you to take any tablets. She should expect some occasional breakthrough bleeding. That can happen. Doesn't happen in everybody, but is it worth warning her? That's a possibility. Sure, sure. So that one's a yeah, you should tell her that. 4, she should also have her partner use a condom. No need for it, is there? No need for it, unless he has an STI, in which case he should use one, in which case you should probably dump him because he's probably not been faithful to you. That's a complete aside. So no, there's no reason, unless there are other reasons. Reproductive reasons are not one of them. So condom, no, that's not necessary. E, this implant also protects against STIs. No, no. Contraceptives do not protect against STIs. There is a myth out there that they do, they don't. They don't. Number 4, your patient is a sexually active 23-year-old lady who's had very good success with the spermicide non-oxidol 9 foam. She complains that her birth canal burns and is irritated after intercourse. There are also some burns around her vulva. Does she have an infection, or is this what you'd expect with the foam? Do you think she has an infection? What's the side effect of the non-oxidol 9? Irritation. So she keeps using it. Might the irritation start to add up after a while? And if she's not been very good about washing it off, might it cause some irritation externally too? So she should probably do a better job of washing it out, getting rid of it, and making sure that her external parts are also free of it. So what does this lady need? She doesn't need antibiotics. She needs instruction. from you, the nurse. That's what she needs. So is this expected? Well, given her practice, probably. So if someone wants to use foam, what are you going to tell them to do? Clean up the extra foam, get rid of the foam, the residual foam that's in the birth canal, yada, 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 so on and so forth. Her partner should also wash it off too, because it can burn the guy too. So wash it off, wash it off, wash it off. A short-term contact usually doesn't cause much irritation. Non-oxidol 9 is a detergent. So it's not, it's kind of like a harsh soap almost. So just wash it off and it should be fine. 5, a patient has just had a progestin-releasing IUD in her uterus. You are left to help her with patient information, which is going to be pretty common in your practice. Which of the following are expectations she should have? That should be an S, sorry, which means that probably more than one is correct. Bleeding and cramping are common during the first week. Is that a potential side effect? Yeah. That may happen during the first week. 2, irregular bleeding and cramping may occur during the first 3 to 6 months after placement. That expected? Who says yes? Who says no? That's a side effect of copper IUDs, not progestin-releasing ones. Now let's look at the next one. Irregular to light bleeding may occur during the first 3 to 6 months following insertion. Is that a side effect of progestin-releasing IUDs? Yes. So number 2, that's with copper. That's with Paragard. 3, that's more common with the progestin-releasing IUDs. 4, light bleeding generally decreases with continued use. Is that expected? Who says yes? Who says no? Yes, because the progestin release decreases. Because it decreases, the bleeding also decreases. So that's actually true as well. So A, C, and D are the things you should let her know to expect. Okay, so you can stick that one in your binder, and when it comes time to review, I hope you'll use those to review. Let's talk about some of the other reproductive drugs. And after this, we will talk about anti-infective agents, antibiotics, antifungals, and things like that. So the first group are the estrogens and the anti-estrogens. So synthetic estrogens, usually the synthetic estrogens that are used today are all steroid synthetic estrogens. And they're used, as you can see here, for primary hypogonadism. What's primary hypogonadism? Anybody remember what that is? That's precisely it. So, but the small, shrunken, subfunctional nature of the gonads is intrinsic to the gonads. Secondary means something else is causing it. Some of the medication that's being taken, maybe they had cancer treatment, something like that. So typically, if you have not had a period before 16, then you are usually diagnosed with some sort of hypogonadism. Now, it's actually kind of common for very athletic ladies to have a delayed first period. So you get gals who, for example, they run cross country, they start running very early and they run a lot. They may not have their first period until later in their lives. So they may have a delayed period, first period. So they may have a kind of secondary hypogonadism. Yeah, that's better. So primary amenorrhea, same thing. You haven't had a period before the age of 16. Some sort of estrogen deficiency, or they can be used in combination with progestins as contraceptives. They're also used for palliative care in people with severe breast cancer. And they're also used in combination with progestins for hormone replacement therapy. And so the main ones are listed there: the ethinyl estradiol valerate, the conjugate esterified estrogens. Premarin is a very inexpensive product that's used a good deal. And then estropipate is another one. The non-steroidal ones, synthetic ones, hexestrol, that's not used typically for these types of conditions. Then there are the antiestrogens. So these bind the estrogen receptor, but they do not elicit a response, and they prevent native estrogen, endogenous estrogen, from binding to the receptor and eliciting a response. So these include the full antagonists of the estrogen receptor and then the selective estrogen receptor modulators. These will shut down estrogen signaling in one tissue but not another. So these are the so-called SERMs. SERMs. And we'll take a look at a few of those SERMs. So the full estrogen antagonists, they're used for breast cancer predominantly. They will work for breast cancer that is estrogen receptor positive. They're not going to be effective in breast cancers that are estrogen receptor negative. SERMs are predominantly used for either breast cancer or for osteoporosis, to prevent or to keep osteoporosis from getting worse. So your synthetic estrogens, there are two that you'll see in books, but they've been discontinued. Diethylstilbestrol, or DES. Women who took diethylstilbestrol and then gave birth to female babies, their babies tended to go on to be infertile. They tended to have developmental abnormalities of the female reproductive tract. Animal studies and epidemiological studies link that infertility to DES. And then mestranol was just recently discontinued last year. The products that are used are ethinyl estradiol and then the others. They come as oral formulations. They also come in injected formulations. They come in transdermal patches and also as vaginal creams. All right, and so these are the various indications that we talked about before. Your synthetic estrogens can stimulate the development of secondary sexual characteristics. They can accelerate growth. So when young ladies have hypogonadism, giving exogenous synthetic estrogen can help them develop secondary sexual characteristics. You have to watch the dosage you give them. Too much synthetic estrogen will cause the epiphyseal plates to prematurely seal. So you must watch the dose very carefully. Again, if you have a failure to have proper menstrual cycles, then you can give synthetic estrogen as well to induce a proper menstrual cycle and start the menstrual cycle from going on. And then after menopause, if you have somebody with a really low bone density, you can use either estrogens combined with progestins or some other product to beef up their bone density. Or you can use a SERM as well. Let's talk about the adverse effects of synthetic estrogens. When taken orally, they can cause nausea. If you take them with food, that will tend to allay that, at least in some people. There are some people who really don't tolerate the synthetic estrogens very well, in which case you might want to go to a different formulation. There's a population of people, they just don't tolerate synthetic estrogen well, at least orally. Most women do. If they get a sour stomach, taking it with food can usually allay that. They can increase cholesterol levels. When used at the dosages that are recommended, this rise in cholesterol levels is not severe, it's usually slight. They will tend to decrease acne, which is a bonus usually for most young ladies in the throes of puberty, since acne can be a problem in those cases. It does increase the risk of blood clots. That risk is going to vary on whether or not you're obese, whether or not you smoke, your diet, your level of activity. The average increase in blood clots is lower than what you'd see, say, during pregnancy. But because of that, you need to educate your patient on what a VTE looks like. And if they get one, to go to the emergency room right away. Does increase the risk of cardiovascular disease. Again, how much of an increase depends on whether or not your patient smokes, what their lifestyle is like, so on and so forth. There is a slight increase of breast cancer, slight increase of cervical cancer, slight decrease in endometrial and ovarian cancer. So slight increase in breast and cervical cancer, slight decrease in endometrial and ovarian cancer. Can also cause changes in breast tenderness and things like that. Those are also things that can happen as well. Any questions about the synthetic estrogens? Again, they come in an IM injection, an oral formulation, transdermal patches, and also in a vaginal cream. The vaginal cream can be used for vaginal dryness or vaginal atrophy that some women experience during menopause. We're going to see there's another product that might be a better choice than a synthetic estrogen. Let's talk SERMs, shall we? So tamoxifen antagonizes estrogen in the breast, but it's a partial agonist for estrogen in the bones. It's also an agonist in the uterus, so you will get some endometrial hyperplasia. It can increase your risk of polyps. Does increase the risk of thromboembolic events. You can also have hot flashes on this medication. Consequently, it gets used in women with breast cancer. Raloxifene is also a SERM, but this one has no estrogenic effect in the endometrium, but it has a robust estrogenic effect in the bone. So this is the drug of choice for osteoporosis in postmenopausal women. You have an increased risk of thromboembolic events, but not as nearly as high a risk as you get with tamoxifen. So this is a good drug for postmenopausal osteoporosis. Clomiphene antagonizes estrogen in the hypothalamus. So because estrogen feedback inhibits the release of gonadotropins from the hypothalamus, clomiphene shuts off that feedback inhibition and you get more gonadotropins. That causes ripening of the ovaries and the eggs in the ovaries. And this drug is used for fertility treatments to ripen multiple eggs that can then be harvested by the reproductive specialist for then in vitro fertilization. It can also be just given to women who are having trouble getting pregnant, but a failure of ovulation is one of the largest reasons for a failure to conceive. Drugs like clomiphene or other drugs like it can help women hyperovulate and conceive. Rebecca? Breast cancer. Breast cancer. If you have an ER positive breast cancer, it's one of the first drugs you're given usually. Okay, I have some nursing implications here for you to look at. Come on. Stop. Oh, good gravy. Stop it, stop it, stop it. Okay. All right, so I don't know if you could read those from back there. I'll just read them to you. You want to, first of all, monitor the effectiveness of the drug. The drug may take a while to work, may take up to 4 to 10 weeks to work. So you need to reassure the patient, oh, the drug's not working after the first week. Well, hon, these things take time to work. So help them to be patient. Didn't work right away. Now, if there's bone pain might mean that it's working, especially if you have a tumor that is metastasized to the bone. So this discomfort usually is a signal of a good tumor response, but bone pain can really hurt. So having analgesics at the ready you can give your patient is really necessary in this case. Now, if you get some sort of local swelling, some sort of redness, erythema, over pre-existing lesions, that might signal that you're actually having a response to tamoxifen. These symptoms will subside. They'll go away. They're not anything to be overly worried about. They can look like heck. They can worry the patient terribly. but they will go away. What sort of labs you want to look at on a regular basis? Of course, the complete blood count, including platelets. You might get some transient leukopenia, thrombocytopenia. Ms. Starr, what's leukopenia mean? Low white blood cells, very good. Erica, thrombocytopenia means? Platelets. Thrombocytes are platelets, yeah. Why don't they just say platelet cytopenia? They don't, but they use the old word for platelets, thrombocytes. So yeah, low platelets, low platelets. And you also want to monitor serum calcium. Since you're dealing with bone stuff, for both of these, serum calcium will be pretty important. You want to make sure to tell the patient not to alter the dose schedule unless told to do so by their physician. So keep to the dose. If you miss a dose, do you double up? No, never. There's some drugs for which you do that, they're rare. Most drugs, if you miss a dose, you miss a dose. You just keep on keeping on. If you have weakness, sleepiness, mental confusion, swelling, trouble breathing, or blurred vision, that might be a sign that the pituitary is putting pressure on the optic chiasm. In fact, that's something with clomiphene you have to really be aware of. Since you're affecting the pituitary, if the pituitary gets larger and it puts pressure on that optic chiasm, could also put some pressure. Remember, the circle of Willis swings around the base of the pituitary. The pituitary grows and it starts to put pressure on those blood vessels. That's going to affect your consciousness. You're going to faint. These are all things that the patient needs to know about, and if they have them, report them. And you might get drug-induced menstrual irregularities. So that's something that they should expect. Now, if your patient is postmenopausal, that's not going to be much of an issue, but all the same. Other things to be concerned about. This is really important for these drugs. Make sure that they cover their skin, protect their skin. They're going to be more susceptible to sunburns. Over-the-counter drugs. Most of your estrogens and most of your SERMs are metabolized by cytochrome P453A4. So are lots of over-the-counter drugs. So when they use OTC pain relievers, make sure that they're okayed by the physician. If there's tenderness or redness in the extremity, they should report it. And of course, don't breastfeed while taking these drugs, in which case, if they're postmenopausal, that's not an issue anyway. Any questions? Now, this drug, ospemifene is relatively new, but it is the only FDA-approved medication for dyspareunia. Natalie, what's dyspareunia? Haven't heard that one yet, or heard it and forgot, or haven't heard that? Did anyone hear that one before? Pain during sexual intercourse. Pain during sexual intercourse. And that's usually due to vaginal atrophy. So this particular medication is FDA approved for vaginal atrophy in postmenopausal women. It is contraindicated in women with breast cancer. Hasn't been studied in such patients. So these types of things, unusual bleeding, changes in vision or speech, sudden severe headaches, severe chest pains, shortness of breath, so on and so forth. Those are usually indicative of allergies to the drug. So if you get an allergy to the drug, you want to report it ASAP. You want to make sure that people are reporting all the other meds they're taking. Notify healthcare professionals of the medical regimen that they're on before any sort of procedure. Yearly exams, quite important. Cigarette smoking, high blood pressure, high cholesterol, diabetes, being overweight during estrogen therapy can increase the risk of heart disease. Don't take during pregnancy, breastfeeding. Notify healthcare professional immediately if pregnancy is planned or suspected. And you might want to discuss the dose and the need for it every 3 to 6 months. This is not a medication that was studied long-term. It was studied relatively short-term. So you want to see if it's working. Is there decreased pain during intercourse? Is there decreased vaginal dryness? That's how you're going to determine if the drug is working. This is the preferred medication for vaginal atrophy. Seems to be safer than synthetic estrogens. Again, this drug is still relatively new. So just keep that in mind. There's less data on it than there is other drugs. And there are other drugs, sorry. Fulvestrant is a full estrogen antagonist, excuse me. So this binds to the estrogen receptor in all tissues and shuts it down. This is used for breast cancer that is resistant to tamoxifen, but is still estrogen receptor positive. You'll notice there are a fair number of side effects to this medication. So injection site effects are pretty common. Nausea, vomiting, loss of appetite, constipation, diarrhea, upset stomach. That occurs actually in less than 1% of people who take it, but it is reported. Body aches, flushing and sweating, hot flashes, trouble sleeping. Those have all been reported, but they're not that common. So if the patient is premenopausal, they should have very effective contraception while taking this medicine. There'll be menstrual irregularities if there is some sort of strange bleeding. They should report that ASAP. Don't breastfeed while on this drug. And that's fulvestrant. The big thing with this is if they have pain, they may have quite a bit of pain. Now, it's hard to know if that pain is a result of the cancer that they have or the drug itself. So pain management might be something you'll have to talk to your patient about. The other big thing with this, since it is a cancer patient, you need to be monitoring just the cancer itself, the progression of the cancer, whether the drug is working. Any questions about the estrogens, antiestrogens, anything like that before I move on? No? Let's go to the progestins and antiprogestins. So progestins are your progesterone, synthetic progesterones. They're called either progestins or progestins or progestins. Some are derived from progesterone itself, others derived from testosterone. So they're used for contraception, they're used for hormone replacement treatment, and the treatment of various gynecological conditions. The antiprogestins are used to induce abortion or for emergency contraception. This medication is also abortifacient. So these will bind to the progesterone receptor, which the crystal structure of it is shown here. You can see it binds as a dimer. And when it binds to the progestin, it gets activated, and then it binds to the DNA and activates the progesterone responsive genes. So the progesterone derivatives include medroxyprogesterone, hydroxyprogesterone, and megestrol acetate. The testosterone derivatives are derived from 19-nortestosterone. They include danazol, which is an older medication and has quite a bit of androgenic properties. Levonorgestrel, another drug we've already talked about before. Desogestrel, norgestimet, and etornogestel. The newer ones are not quite as androgenic as the older ones. So the progestins are going to decrease the growth and increase vascularization of the endometrium. They will thicken cervical mucus. They cannot support a pregnancy like endogenous progesterone, but under certain conditions, they can help with one. So they're used for HRT in postmenopausal women who have an intact uterus. If they don't have an intact uterus, there's no point. They can mitigate the pro-proliferative activities of estrogen. They can also be used to diagnose gynecological conditions. So if you have something called intrauterine adhesions, so-called Asherman syndrome, you are given the so-called medroxyprogesterone test. In this case, the lady is given 10 milligrams of medroxyprogesterone orally. She's given that for 10 days, and then the uterus should start to bleed. If there's no bleeding, then you give estrogen to thicken the uterus and you try again. And if you don't get bleeding, then you have uterine scarring. And that would explain why embryos are not properly adhering to the uterus. So they're used for gynecological tests like that. They're also used for endometriosis. Rebecca, what's endometriosis? Yeah. So the lining, instead of going out with the flow, the menstrual flow, those cells somehow go the wrong way. And they can be they can be in the fallopian tube, they can be outside the uterus, they can be in the abdomen, they can be in the lungs. And those tissues then, with every menstrual cycle, will proliferate, slough, and bleed. that means you now have a good deal of internal bleeding that occurs with every period. It's very painful, very painful. So these medications, because they're anti-proliferative, they can very much take the edge off endometriosis. So the adverse effects of progestins, at low doses, they're usually quite well tolerated. Reported side effects include things we've talked about already: fluid retention, therefore consequently increased blood pressure, mood changes, mainly depression, fatigue, breast discomfort, usually tenderness, changes in sex drive, libido, some menstrual irregularities. Those are low frequency events. If you take them for an extended period of time, high doses, you can have decreased bone density and delays in resumption of ovulation after you end the treatment. So what sort of things do you watch for? If there's an injection, the intramuscular injection can be painful. You want to watch for venous thromboembolism. So-called planned menstrual cycling with medroxyprogesterone. If you're doing oral medroxyprogesterone, will benefit those who have history of abnormal uterine bleeding. The bleeding then will tend to occur with the menstrual cycle. Make sure women who are on progestins perform a breast self-examination. If they don't know how to do one, show them how to do it. Don't breastfeed while on this drug. Make sure that the package insert is read by the patient, that they understand how to take the medication, and that they follow that as listed. Those that have testosterone, those synthetic progestins derived from the 9-nortestosterone have additional side effects, and they include, they can make your acne worse, they can deepen your voice, they can cause the growth of hair in places you don't want it, like on your face, and they can cause increased secretion of sebaceous glands, something called seborrhea. That's why they make the acne worse in some cases. The newer derivatives don't tend to cause a virilization, but they still increase the risk of venous thromboembolism. The antiprogestins, as we said, are used for medical abortion. They are FDA approved for the first 50 days of pregnancy. Within that time period, they are 90 to 95% effective. They are used off-label, outside, 50 days. For every week, their effectiveness goes down about 10%. They're given with a prostaglandin, usually misoprostol, but also gemiprost as well. This will cause a uterus essentially to contract and expel the fetus. This again binds to the progesterone receptor, prevents it from working. So you have the 2 pills. You take the mifepristone first. This is a drug that was called for years RU486, the so-called French abortion pill, because it was developed by a Abbott Corporation when their headquarters was in France. So the drug insert says nausea, vomiting, and diarrhea. I have read online some chat rooms of women who've taken this. They say that the pain, the stomach pain is ridiculous. So nausea, vomiting, diarrhea is pretty tame. Most women, at least in that chat room, said that the stomach pain was pretty wrenching. Bleeding is pretty common. Some women get infections of the uterus by Clostridium sordellii. And the fetus, well, at that stage, it's an embryo, is usually released into the toilet, usually. Again, via that chat room, most women see it in the toilet. Ulipristal, this is the drug that goes by the trade name Ella. Mifepristone is Mifeprex. That's a trade name. Ulipristal is given for emergency birth control. Because that drug is not as powerful as mifepristone, it does not have the same side effect profile, but it does tend to cause nausea and what have you. Ulipristal is not intended to be taken multiple times, supposed to use it once. If the drug is vomited up, you can retake it 3 hours later. Personally, if I had my way, this would not just be given by, take this by, your problems are solved. This would be taken essentially under the watchful eye of a healthcare provider, because they don't like to tell you this, but women have died on this drug. So safe way to end your troubles? I think not. That's all I'm going to say about that drug, those drugs. All right, this is a good time to take a break because we'll go to the androgens next, androgens and anti-androgens, and then go to the PDE5 inhibitors after that. And yeah, I think that's a section. So go ahead, take 5, and then we'll resume.
Are you serious?
So Maddie, was it just you and your husband for Easter, or did you go over? Went to your parents' house? Mm. Are your sets of in-laws all close? Lapeer, that's a drive. That's a drive. We go to Lapeer for a Bible quiz every year. That's a drive. He did. Huh. Does he know the Harris girls, Julianne Harris and Allison Harris? They quiz with Lapeer. Yeah. Okay. Small world. Who'd have thought? All right, folks, let's go ahead and get back in the saddle. So androgens are like, testosterone is an androgen. And so if you're going to give androgens, usually you give testosterone or some derivative thereof. There are two main types of synthetic testosterones. There are the testosterone derivatives and then so-called anabolic steroids. Anabolic steroids. These bind the androgen receptor. There are a couple different isotypes of the androgen receptor. These will usually bind all of them and activate it, and it's given by, as you can see, a patch. Also, there are implants that release testosterone. And there's also little buccal strips that you give. There's also a form of testosterone. I saw it advertised. It was released a couple of years ago. It comes as an underarm deodorant. So you put it under your arms like that. And I forget what it's called, but testosterone also comes kind of as a speed stick kind of deodorant thing you put under your arms. I have no idea if it makes you smell nicer. So there are two main testosterone derivatives, so-called fluoxymesterone and then methyl testosterone. Then there is a testosterone ester-like drug called testosterone cypionate. That's a long-acting androgen. That particular long-acting androgen is given as an IM injection, and it is a depot injection. You use this in guys who have hypogonadism and some sort of delayed puberty. So in physiology, or you probably went through the Tanner stages of sexual development. That ring a bell? The Tanner stages? No? You'll learn it in another class probably. The Tanner stages essentially help you assess the sexual development of a young guy or a young gal. And the Tanner stages have to do with secondary sexual characteristics and how well those characteristics are developed. There's a stage 1, 2, 3, 4, 5. They're supposed to hit those stages at certain ages. If they don't hit those stages at certain ages, then they have some sort of hypogonadism or something like that. You can use testosterone essentially to help a guy with hypogonadism. And this again can be primary or secondary, essentially be able to get to full development of secondary sexual characteristics. And these are also used to help people recover from burn injuries or help those with wasting syndromes, people with cancer or HIV to be able to regain some body mass. So used for that as well. As you might guess, testosterone derivatives have a fair number of side effects. If they're used in females, they will masculinize females. So they are used today for this gender affirming treatment. Don't get me started, so I won't. So if you take them illicitly, they decrease luteinizing hormone production, and they'll actually paradoxically cause testicular atrophy. They can cause gynecomastia and infertility, premature closure of the epiphyseal plates. That's if you don't get the dose right. And they also jack up the LDL substantially in most cases. They decrease the HDL, and they can usually lead to obesity. Anabolic steroids include nandrolone and oxandrolone. These are used to increase muscle mass and increase red blood cell production. Their clinical use is limited, but the main use for these is for aplastic anemia. Aplastic anemia. They've also been used illegally by athletes. So these cause the same sorts of side effects as cholesterol derivatives also. They can cause something called cholestatic jaundice. The bile salts do not properly undergo conjugation and disposal, so they get deposited in the skin. They cause jaundice and very intense itching. They can increase liver enzyme levels, and they increase the risk of hepatocellular carcinoma. And they increase the risk of coronary artery disease. So for your nursing evaluations, you want to make sure you get a baseline liver function test and electrolyte levels. That we have something to compare to. You want to make sure you're looking for signs of liver health. Also look for electrolyte imbalances in the form of hyperkalemia or hypercalcemia. And then monitor diabetics. Their glycemic control can really be messed up by testosterone. In women, the drug will cause virilization, increase facial hair, increased body hair, deepening of the voice, change in mood, sometimes almost a manic sort of manifestation in the mood. Anti-androgens, there are several of these that are used to treat prostate cancer. The ones I will introduce you to are flutamide and spironolactone. They are used to treat prostate cancer. So these, the list of side effects there is really common for antiestrogens, anti-androgens, sorry, anti-androgens. So gynecomastia, enlargement of the male breast tissue, hot flashes, breast tenderness, sexual dysfunction, decreased sex drive, erectile dysfunction, nausea, vomiting, diarrhea, really common for anti-androgenic drugs. So all of these drugs here that are used for prostate cancer have essentially that similar side effect profile. You don't get all those same side effects in people, but you have very similar side effect profiles for really all these drugs. We'll cover these drugs when we get to anti-cancer drugs. For now, just flutamide and spironolactone. Somebody else who wants money. Nope. Spironolactone is a drug we've seen before. This is one of those potassium-sparing diuretics we talked about. This gets used to treat the growth of facial hair in ladies with polycystic ovary disease. It's also used to treat male pattern baldness. Side effects are amenorrhea in women and gynecomastia in men. You really need to monitor potassium levels with this drug. Because it is a diuretic, you also want to make sure you monitor blood pressure. The best way to monitor for the diuretic effect is body weight. As they start to lose water, their weight will usually start to go down. If the patient has ascites, you also might want to get a belly mass, a belly width as well. If patients have liver disease, these are some signs that might indicate that blood ammonia levels are starting to climb. Mental changes, lethargy, or stupor. Those are all things that should worry you. So educate the patient on the signs of hyponatremia and hyperkalemia. They're most likely to occur in people with severe liver disease. So weigh the patient at first, 2 to 3 times a week. Don't engage in hazardous activities until the effect of the drug is well known. The drop in blood pressure may increase the risk for falls in some patients. Avoid excessive intake of high potassium salt substitutes. That'll jack their potassium up even more. And of course, don't breastfeed while taking this drug if the lady is breastfeeding. Okay, questions about the anti-androgens or the androgens or what have you? The 5-alpha reductase inhibitors. So these prevent the conversion of testosterone to dihydrotestosterone. And the enzyme that does that is 5-alpha reductase. 5-alpha reductase inhibitors prevent DHT production. DHT enlarges the prostate in older chaps. That's what causes benign prostatic hyperplasia, BPH. This drug can shrink the prostate. So there are a couple of drugs like this. The one most commonly used is finasteride. This drug is also used to promote growth on the hair and prevent pattern baldness. It can cause, usually it's pretty well tolerated, but it causes gynecomastia, infertility, and some sexual dysfunction. Not as much as other types of treatments. For this drug, you want to make sure that the person, because with BPH, being able to urinate is an issue. And so you want to make sure that the drug is working, that the patient can properly urinate. Now, the drug takes a while to work, takes a while for the prostate to shrink. They will see results usually within 6 months, but not great results before that. So you have to have the patient be patient. The patient must be patient. Aromatase inhibitors. Aromatase inhibitors. These inhibit the formation of estrogen from androgens. They're induced by gonadotropins. If you give these to premenopausal women, they'll increase the production of gonadotropins and estrogen. If you give them to postmenopausal women, they decrease estrogen in estrogen-dependent cancers. So they're usually only given to postmenopausal women. There's 2 types. Type 1 are competitive aromatase inhibitors. Type 2 are non-competitive. Those are non-steroidal. So the type 1s includes exemestane, and the type 2s include anastrozole and letrozole. These, fortunately, are pretty well tolerated. So the side effects you see listed there are low frequency events. Low frequency meaning less than or equal to 1% of the people who take these medications. There is an osteoporosis risk. You want to usually give them with bisphosphonates. The drugs fortunately play well with bisphosphonates. Some report menopause-like hot flashes, night sweats, vaginal dryness, loss of libido. Those are all menopause-like symptoms. If the lady's gone through menopause, that's usually not an issue. Joint pain. Disc herniation has been reported, but it's not at all common, and it's difficult to know if that's linked to the drug. Letrozole can cause nausea and hair thinning in some people. It has less cardiovascular side effects. Exemestane causes some nausea and fatigue, and it can also cause some visual disturbances. So if someone is on exemestane, you're going to give them an eye test, aren't you? You're going to give them an eye test. And if they're on the other drugs, the non-steroidal drugs, they should have a bone scan, usually once every year, once every 2 years, something like that. So if the drugs cause your stomach to be upset, then take it with a small meal. You can take these with or without food. If they upset your stomach, take it with some victuals. Chest pain, palpitation, shortness of breath, that's usually allergies to the drug. Allergies to the drug are not at all common. They have been reported, though. So with exemestane, you're going to get regular liver functions. That means you need a baseline where to go on it. The blood nitrogen, blood urea nitrogen and creatinine, you need to check those. White blood cells, lipid profile, routine blood chemistry, they need to have this done yearly on a regular basis. Have the patient read the drug insert so that they know what they're getting into, know what to expect. Of course, don't breastfeed when you're on this drug, but if you're postmenopausal, it shouldn't be an issue in the first place. And seek medical attention if you have chest pain, calf pain, shortness of breath, unexplained loss of appetite, nausea, jaundice, things like that. That might be liver failure or a clot. Those would be things you want to worry about, but they're not common. But if they do occur, then you want to be ready for them. Any questions about aromatase inhibitors? Okay, PDE5 inhibitors. These are the ones, I'm sure you've seen those tasteless commercials in the gym on ESPN for Viagra or this other stuff like that. These really dumb commercials that clog our television screens. So these are the whoopee pills, essentially, that are used for erectile dysfunction. They have other uses, though. They're also used for respiratory hypertension. And so these inhibit phosphodiesterase isozyme number 5, which breaks down cyclic GMP to the inactive form GMP. Cyclic GMP is made in response to nitric oxide in smooth muscle. Cyclic GMP, as you can see, does two things. It activates a cyclic G-dependent protein kinase G. It phosphorylates a calcium channel, closing it, and it phosphorylates a potassium channel, opening it. So now the smooth muscle cell has less calcium, and then it becomes hyperpolarized. So it relaxes. So this promotes smooth muscle relaxation. That is precisely the smooth muscle relaxation that occurs in the erectile tissues of the male penis. That's why they're used for erectile dysfunction. So there's 4 of those drugs. Notice how they end: sildenafil, vardenafil, tadalafil, and then a new one, avanafil. Notice they all end with afil. So you're filling the erectile tissues. That's my dumb way to remember them. You fill them, so they're afillin. So then afil, tadalafil. Okay, it's stupid, but it helps you remember it. It helps you remember it. Tadalafil is also used for benign prostatic hyperplasia. It doesn't shrink the prostate, but it does relieve symptoms. That is, it will help you tinkle with an enlarged prostate. These drugs are also given for pulmonary hypertension. Increased blood pressure in the pulmonary circulation that's greater than 25 torr. They're very effective for that, in fact. Adverse effects include drop in blood pressure. So orthostatic hypotension can be an issue. Flushing tends to be more of a first dose effect, flushing, but it's reported. Headache. Some sort of stomach issue with burping and early satiety, probably because of vasodilation in the GI tract. Some vision impairment, where things get blue tinted. That's called cyanopia. Do not use these with organic nitrates. They will drop your blood pressure like a rock and cause a heart attack. Because these drugs tend to be short-lived, except for tadalafil. Tadalafil is it's tastelessly called the weekend pill. Sorry, I have to subject you to this, but because of its long half-life. These drugs usually are short-lived and they're pretty well tolerated. Also because it's usually a guy thing. After you have intercourse, guys usually go, usually the side effects they might have, they sleep right through them. So they're usually well tolerated. Is there a kind of a side effect when you wake up with tadalafil? There might be, but usually after guys take it a few times, they tolerate it just fine. These pills are usually pretty well tolerated. So now you can get these drugs now online with these online doctors. So guys might be taking these and the doctor may not know it. That can be dangerous. So when you do the workup with the patient before the physical, what are you going to ask? If it's a guy and he's say middle age, where guys start having trouble with their equipment, shall we say, what are you going to ask him? So do you have a prescription for any of these erectile dysfunction medications that we don't know about? Just, we need to know, just for your safety. We need to know. Don't be afraid to ask. Now, if they tell you it's none of your business, that's what they told you, but you asked. You might save their life by knowing. All right. They should also probably have an eye test before they go on these. So if they don't see an ophthalmologist or an optometrist regularly, they should probably make an appointment, which nowadays at Walmart, you can do one at Walmart and have an eye exam quickly and cheaply, pretty easily. All right, does anyone have any questions about any of the things we've talked about? No, Natalie. Just a joke. Okay. Anything from Wednesday, the contraceptives, any of that stuff that you have questions about? No? Very good. If you have the handout then that I emailed to you, please get that out. So those of you online, I sent you a handout about antibiotics. Please check your email for it. If the email didn't go through, let me know. I will resend it. All right, the next section is the anti-infectives. These are drugs you will use a great deal in your practice. So it's incumbent upon you to know how they work, what they're for, and what sort of things you need to watch when someone is on these medications. So the first drugs on there are the macrolide antibiotics. So that includes the granddaddy of this group is erythromycin. Then there's the newer azithromycin. That's the one you get in a so-called Z-Pack. Clarithromycin, fidaxomycin, which is not really a macrolide, but it gets grouped with the macrolides. And then telithromycin, which is a ketolide. And if the FDA has any self-respect, they will pull this drug soon because that drug is dangerous. In fact, put a little star next to that drug on the handout. Go ahead and put a little star next to it and just write next to it, dangerous. telithromycin. Patients on that drug all of a sudden who are totally healthy have unexplained liver damage, and they die from it. The FDA should have never approved that drug. So these are protein synthesis inhibitors. They inhibit bacterial protein synthesis. Now, fidaxomicin is different. Fidaxomicin inhibits bacterial RNA polymerase. Fidaxomicin is not absorbed when you take it. So what's it used for? If you go all the way down towards the bottom of the page, it's used for Clostridioides difficile. It's used for C. diff infections. It's very effective against C. diff infections. In fact, it's now the drug of choice for C. diff infections. So fidaxomicin, bird of different feather, even though it's kind of flocking together with the macrolides. What are these drugs good for? They're very good for atypical microbes, things like mycoplasmas that cause walking pneumonia. They're very good for things like Legionella. Remember, Legionella is resistant to a lot of cephalosporins and beta-lactam antibiotics. It's very good for Helicobacter pylori, which causes stomach ulcers. And it's good for Mycobacterium avium. So pretty broad spectrum. They're also good for most of your streptococci, albeit resistance to these drugs is increasing amidst the streptococci. So if you use them for streptococci, use them with some caution. Not good for anaerobes, not good for enterococci, terrible for staph. And enteric bacteria, not great, albeit azithromycin can be used to prevent traveler's diarrhea. It's good for that. None of the other macrolides are really any good for that. These drugs are usually, when taken as dosed, are well tolerated. But what sort of side effects can you expect? Well, some GI disturbance can occur, albeit is not at all common. Hepatic events, the big culprit here is telithromycin. So if you use this drug at all, use it with tremendous caution. In fact, I think it might be your duty to take the provider aside and say, please don't give that drug. And if the provider doesn't listen to you, you did your job. But that's a drug that just say, when I was in nursing school, my professor said that drug should be pulled. Oh, is your professor a doctor? Yes. Erythromycin is probably the drug that is the worst culprit of elongating the QT interval. Now, it doesn't usually do that at standard doses, but if they're on something else that increases the QT interval, erythromycin can make that worse. Then you're at risk for torsade de pointes. So you're going to check their med chart. You're going to see if there's anything else on there that increases the QT interval, aren't you? They strongly inhibit cytochrome P453A4 with the exception of azithromycin. Azithromycin plays well with other drugs that are metabolized by 3A4. All right, some fast facts you could see there. Azithromycin is a long half-life. That's why it's given as a Z-Pack. Just 5 pills, usually lasts you a whole 10 days or so. These drugs are bacteriostatic, not bactericidal. So if you need to kill the bugs, meningitis, endocarditis, things like that, these are not your best choice. Great for respiratory infections, great for traveler's diarrhea. Azithromycin in particular not only kills microbes infecting the upper respiratory tract, it has an interesting anti-inflammatory effect as well. That's why it's particularly good for upper respiratory infections. So it's used a lot in people with cystic fibrosis who get upper respiratory infections a lot. It's good for that. And then fidaxomicin. I say fidaxomicin, you think in your head C. diff. Okay? So I say fidaxomicin, you say C. diff. Ready? Fidaxomicin. Thank you. Fidaxomicin. C. diff is treated with? You guys can become Bible quizzes overnight. That's how we do it in quizzing. All right, we will continue this on Wednesday. We'll go through the handout. We'll go through the antifungals and the antibacterials and what have you. Some of this is review from micro, so I'm going to go through this kind of fast since this will be your second pass at it for most of you. The rest of you, please, oh please drive safely on your way back. And don't forget, we have a quiz on Wednesday. The quiz will not include any of the antibiotics. It'll just include the reproductive drugs we talked about, okay? Very good. Have a good evening. Drive carefully. Stay well.